sleep. So tomorrow the world you can see. And if you are an inheritor of some eye disease or disorder, then check your doctor regularly. So for a longer time you can see.
10.5 minutes after 6 o'clock in Trinidad and Tobago and the Eastern Caribbean. Good evening or good morning wherever you are around the world. Welcome to the Mended Studios Facebook platform as we present the PAVI segment for this month, the month of April, my birthday month. I had a very nice time on Saturday. Thank you to all those who sent birthday wishes to yours truly. On the program this evening, we have Dr. Declan Mahabir, the son of Dr. Boise Mahabir. It's like father, like son, and we'll be talking about eye care, eye diseases, and the things we should or should not do. Technical operators by Julian. So before we get into the meat of the matter, let's take our first commercial break.
Courtesy is a presentation of Persons Associated with Visual Impairment, Episode 1.
Gosh, boy, like we late. Let me go and sit down quick, eh?
Wrong seat, son. Wrong seat.
Oh, gosh, man. When will you learn to guide me properly, boy? I tell you. When we enter a room, give me the heads up. Tell me how the chair is situated and guide me to one. Put my hand on the back of the chair so that I could check to make sure it's safe to sit down on the chair. Look how you make me sit down on the woman lap.
Me, partner, don't blame me now. It's you play Mr. Punctual and hurry to run and sit down. Anyhow, one good thing I could say, you would have the best seat in the room.
This is so embarrassing, eh?
Hi, yes. I'm not hearing anything. Just your good self. Is your mic? Yeah, mic's on. You came through so clearly there a few minutes ago. Yeah, unfortunately, I'm not hearing you, Brewani. But if there are questions, you can put them in the chat, and I'll be able to see them. Okay, there you go.
Right, you hear me now? For some strange reason. All right. Well, let's say a bad beginning will make a happy ending. So, welcome to the program. We do apologize for the little technical glitches that we've been having, but now that we have sorted it out, I want to welcome Dr. Declan Mahabir. I'm getting a delay, Julian, so if you saw that out. Right, but so Dr. Declan Mahabir, welcome.
Thanks, guys. Thanks for having me on the show. It's great to be on.
Yeah, and we do apologize for the glitches. It's due to circumstances beyond our control, so we'll make up with that. Dr. Mahabir, you are, well, an eye specialist, just like your dad, and I suppose you're following the footsteps of him. In terms of eye diseases, now I know that people are accustomed hearing that the major causes of blindness are glaucoma, cataract, and diabetes. What I would suggest is that you touch very briefly on these three because we don't want to spend too much time. They have been repeated over time and time again. So, and then we want to look at things like macular degeneration and that kind of stuff. So if you give us a little 5 minutes on the major diseases that people are accustomed to.
Sure, absolutely. Maybe I'll start with cataract. Cataract is really a natural clouding in the lens within the eyes. I think going back 30 years, it was a major cause of blindness. But I think in 2021, there's been a lot of effort, infrastructure, skill development, and facilities developed so that we can tackle the cataract issue. And I have to say, if you go back to when we looked in 2000, I think in 15 or 16, I can't remember which year it was, we did a nationwide count. And the WHO had put out some guidelines for first world countries. And above that was US and Canada. And then they had a section, like a number count of cataract surgeries for those people in third world countries. And basically, if you were under 3,000 cataracts per million per year, then you were really sort of looking at third world values or healthcare system. If you were between
Dr.
three...
Dr. Declan, before you go on, I don't know if you are in a position where you're getting plenty breeze, but we're getting a lot of background noises.
A lot of background noise. Okay, I am a little bit outdoors, but that's no problem. So I'll solve that for you now. Okay. So in a nutshell, 3,000 to 5,000 per million per year was essentially kind of coming into first world countries or developed countries. And if you surpassed sort of 5,500, 6,000, then that was really on par with the United States and Canada. And when we did the count for 2015, the numbers were, I think it was 5,500 per million per year for Trinidad. So that basically put us just below the US and Canada for number of cataracts per population. So I think we are doing amazingly well, and I think we've sorted that problem that in terms of dealing with cataracts, Trinidad is really very high on the scale. Glaucoma and diabetes. The problem is when you compare our population to countries like the United Kingdom, 2% of their population have diabetes. Of that 2%, I'd say up to 10% of those, so 0.2%, have sight-threatening disease. When you look at places like Trinidad, we know that within the African population and within the Indian population, that they are 6 times higher or more likely to have diabetes in their population. So when we look at the prevalence or the incidence of diabetes within the population, we are actually hovering around 13%. And I know, speaking to my colleagues in Barbados, they think their statistics are closer to 20%. And if you're looking at 20% of your population having diabetes, and 1% of those having sight-threatening disease, we have 10 times the problem than developed countries like the United States and United Kingdom have, and Europe. So, per population, we are 10 times higher than everybody else. And we also know that in diabetes, things like hypertension, high cholesterol make it so much worse. And in particular, in Trinidad, we have a hypertension problem as well. So we have a hypertension problem and a diabetes problem that really work synergistically to make it really, really difficult to win that battle. And I did a lot of my training in Ireland, spent some time in England, and we had bad disease there. But, coming back to Trinidad, it was a different spectrum. The severity level was really quite high. Sometimes you do everything correctly, in inverted commas, and you still have a lot of difficulty. So, and then as well, again, back when I'd come back to Trinidad in 2005, 2007, we had, an educational problem where we needed to educate the population about these sort of statistics and the epidemiology of the disease here. And also, you got to realize that about 15 to 20% of those statistics are going to be people under the age of 30 as well. So that's why I guess diabetes is talked about so much. We have a huge problem in the Caribbean and the West Indies. And it can be a little bit difficult to get on top of. Having said that, in the last 15 years, the options that are available for patients have expanded greatly. The kinds of things that are out on the market and the kind of things that are coming out on the market are really exciting. And there's great anticipation about treating disease really more with a lot more efficacy, and I think it's going to be really exciting. So the research and development is being done on new drugs and on existing techniques to improve them. So the outlook is very bright for, in particular, diabetics. Coming to glaucoma, I'm just going to give you some hard statistics again. The number one place in the world for glaucoma is essentially Africa. We know that the genetics in Africa lend to really severe disease. And again, I did a lot of my training in England, did a little stint in, Ireland, sorry. I did a little stint in England, and, I saw glaucoma, and, I'd say it's not the hardest thing to treat. We had a couple patients that were difficult, and they were really successful with surgery. Glaucoma really starts in your mid-40s, generally accepted worldwide. And, we do a lot of screening around that time. But, if it runs in families and we see people developing in families glaucoma a lot earlier, then essentially, we may screen that particular group of that family maybe a little bit earlier, okay? But when in Trinidad, I have seen things that I have never seen before. And it's scary. So I have seen people blind, diagnosed with glaucoma in their teens. My colleagues are saying there are people being diagnosed earlier with primary open-angle glaucoma, and essentially speaking, I'm seeing in particular one girl who I'm very passionate about, and she was essentially blind by the time she was 28. It's really aggressive in a subpopulation within Trinidad, and it's not reversible. It's not like you come with advanced glaucoma and then we can just sort of say, we give you a tablet or an injection or something like that, and we give you back what you've lost. Once it's gone, it's gone. It's painless. It does not hurt. And you cannot tell if you have glaucoma sitting at home, putting your fingers in front of your face and just trying to figure out if you have the signs or symptoms of glaucoma. It is something that you need to come in and check with an ophthalmologist or an eye surgeon, essentially, to figure it all out. And even with us, we need a lot of testing, visual fields testing, OCTs testing. OCTs are like MRI scans, but give you anywhere between 100 or 1,000 times more information than an MRI scan can ever give you. And we're able to detect glaucoma earlier and earlier. So I think really that's probably the synopsis. I think a reasonable synopsis for people, even if you've never heard of those three conditions, to get a pretty big, a good enough idea of what we are facing. And glaucoma, diabetes, and cataract are ranked number 1, number 2, and number 3 for blindness. So cataract is reversible, glaucoma is irreversible, and diabetes is somewhere in between. So with that, I'm just going to pass it back to you, Mr. Prasad, to guide me if I can clear things up a little bit more for you, if there's something else that you wanted to pass.
No problem. I just want to remind our viewers/listeners that we are unable to take any telephone calls. Everything is done remotely today. So what you can do is, if you have a question, you can send it to the Mended Studio Facebook page, and we will try to answer it as best as humanly possible. Sorry, we can't take any calls, but the circumstances are a bit challenging this evening. All right. I want to congratulate you on your stats, Doc, because of the fact that, one of the challenges we hear in Trinidad and Tobago and the Caribbean is poor statistics. You get all kinds of figures being branded about. But what you have done is to put into context what the situation is. Now, I could tell you in my time, when I was born, something was going over the eye, and in those days, technology was not what it is today. But at the same time, all it did is treat the eye. Whether it got better or it got worse, that was a next story. But you have to deal with it. The situation with young people becoming blind, I know that it is a concern not only for them, but for their parents, for their peers, because a lot of people still live in denial. Do you share that, Doc?
Absolutely, thanks. That's a wonderful point. A lot of times, so I'm with the University of the West Indies, and we do some training for junior doctors, and it's really important that we leave a legacy of people who will carry on the profession at a very high level, and we're dedicated to it. It's 3 ophthalmologists so far. It's myself, Dr. Desiree Murray, who's a fantastic lecturer. She's been at this for 15 years. Dr. Robin Sumangal, he's also dedicated to the training of the junior doctors and leaving a legacy behind that will mean that we're in good hands. I usually tell people when I'm training young doctors that, okay, surgeons operate, and the worst thing that can happen is the patient dies. In ophthalmology, the worst thing that can happen for us, the equivalent, is blindness, and this is something every doctor in every group of medicine is trying to avoid: mortality and morbidity. So people who are going blind or who may be somewhat visually impaired, and that sometimes happens from disease, that sometimes happens from procedures, complications of procedures like infections and high pressures, and you can develop glaucoma oftentimes with procedures. So it is something that we look to avoid, but in particular, we really wish to avoid it in younger people. And if you look at the international movement for the last, I don't know, maybe 50 years, let's say 30 years, okay? It's prevention. It's primary prevention. It's finding things early. It's screening the population. It's knowing your population. Because I know you're going to want to talk about age-related macular degeneration, and I am happy to talk about age-related macular degeneration for you, but it doesn't happen in Trinidad, okay? So here it is, we live in Trinidad. I see age-related macular degeneration maybe 2 or 3 times for the year, and when I was training, again in Europe, I would see 2 to 3 new cases per week there, and they're very aggressive disease. So there's a spectrum of disease depending on where you live. We also know there's other conditions like uveitis, not often talked about because of it can be very complicated issue to talk about. But in a nutshell, uveitis varies according to geography. We know that in Japan, they oftentimes get VKH, Volk Harada Koyanji syndrome. I might have seen it only 2 or 3 times between Europe and here, being in Trinidad. So we know that HLA-B27 related uveitis as well is quite common in Europe, but it just hasn't worked out the same way here. Same way in Trinidad, I want to say. Yeah.
We'll come back to the discussion at 6:30 and a half. We need to take a good commercial break so you can get a quick drink of water and we continue the discussion.
Thank you. I will.
Okay, Julian, it's all yours.
Courtesy is a presentation of persons associated with visual impairment. Previously on Courtesy.
Excuse me, Mr. Gentleman. I noticed that instead of addressing me directly, you are speaking to my wife and expect her to speak for me. I want you to know I am not speech or hearing impaired. I just happen to be blind.
And what are you having, sir?
Sir, neither am I hearing impaired. There's no need to shout when speaking to me.
And now, on episode 6.
Hey, soldier, you might be across the street hour.
No. Hey, thanks, eh? But you're doing this thing the wrong way. You can't lift me up and carry me across the street, man. Here's how to do this. Let me hold you just above the elbow. And you walk a step ahead of me. Let me know when to step up and when to step down. And we'll cross together.
Oh, you saw to do this thing?
Thanks, eh, man.
Yeah, bless one, bless up.
To read it fast, and also that if you want to support this initiative, because we try to have a program every month on blindness and related issues pertaining to blind and visually impaired persons, and you want to contribute financially, we welcome it. It costs us $1,000 to host a program like this. So if you want to be a contributor, a donor, without being mentioned and that kind of stuff, you can do it. If you want to be mentioned, well, we have no problems. Like our friends at the people who made it possible call fire this month, but just remember that we need to thank them for their support of this initiative, and you can also give your support in whatever way you can. We're continuing with Dr. Declan. We want to talk about some of the other diseases now. Macular degeneration is well known to us. We know that rubella at one time was a biggie in places like Africa, like Asia, and it's caused from German measles, all of these things. Doc, I am no doctor, but I'm trying my best to remember what I learned. Suffice it to say that we don't have much of this happening in this part of the region.
Absolutely. Well, I think that really came about through vaccination. So it's a hot topic at the moment, the benefits of vaccination. So the MMR vaccine is measles, mumps, and rubella, and that is given within the first few weeks of life in most countries. So we're finding that, yes, you're right, German measles, rubella is not a large contributing factor towards death. So mortality and morbidity. So morbidity is where you don't die, but you end up being disabled in some way. So vaccinations are really, really important. And I just want to chime in and sort of say, given the worldwide global pandemic that I want to advocate that people over the age of 50, definitely 60, are taking advantage of those opportunities that we're getting in Trinidad right now for vaccination. I know it's a hot topic. It's maybe not everybody's in agreement, but just as you mentioned that, I'm mentioning that as well. Okay, the under 40s. I'm a bit divided in my opinion. But certainly in the over 50s, over 60 category, it's undisputed that vaccination's extremely important. Obviously, if we can get things like Pfizer vaccines and stuff, I think it'll be much better for us. But we've got AstraZeneca, so my opinion is anybody who's going to be likely to be exposed in any major way should absolutely avail of the AstraZeneca vaccine. But yes, I was just finishing my point on uveitis, because we need to know our population. We need to know the epidemiology, and you brought it up and you're absolutely spot on. So uveitis is an inflammation of the eye. It can be quite devastating for some people. And so whereas HLA-B27 related uveitis would be probably more common in Europe, that would certainly not be the case, for instance, from Turkey to China, but we know that Behçet's disease is far more common in that area. So you're right. Knowing your epidemiology is extremely important. And I think the biggest problem right now is that in Trinidad, there hasn't been an awful lot of epidemiological work, especially in cases like uveitis. So those are things that people who are doing research in Trinidad are hopefully looking at solving for us. So so we want to avoid blindness. We definitely want to avoid blindness in the young population. It's very, very, very difficult to see a younger person develop severe disease and visual impairment as a result. So we fight very, very hard. And as I said in my opening statement, there's never been a time where we've had more facilities available to patients, to avoid blindness. There are certain things I think that the public system have to work on, but I'm really just not going to make too much of a comment on that. They're not too keen on doctors making comments on the public system, but there are improvements I think overall that we can to make it better for avoiding visual impairment in Trinidad.
Right, going back a little bit, I know again in Africa, like you had the rubella, understand. You also had river blindness, which we do have here.
Absolutely, the WHO spent a lot of time actually driving the use of ivermectin in the treatment of lower, and it is a parasitic worm that essentially caused blindness. And you're right, it's called river blindness. It's essentially, I think, just it affects South and Central America quite a bit, and I think it's just, if it's not completely eradicated, it's pretty close. It's just down to a few areas that are left. But the aim was complete eradication by 2020. And I remember the WHO representatives coming to OSWI, which was the Ophthalmic Society of the West Indies, about 15 years ago, talking about the eradication of lower by the use of ivermectin. The other thing that you would hear about in Africa is trachoma, which is a chlamydial type infection, and oftentimes they get reinfected. It's got a lot to do with hygiene and those issues, and it causes a lot of scarring in the anterior segment or in the conjunctiva cornea. That's pretty irreversible or difficult to treat once the disease has taken hold. And if I'm not mistaken, I don't want to call names and end us in trouble, but there were companies that donated azithromycin 1 gram stack doses to eradicate trachoma in areas of Africa. I know for sure, in areas where it was prevalent. So yes, there are programs all the time where they figure where there's a high prevalence of a particular disease, it's difficult to reverse. You're going to find societies like the WHO stepping in to eradicate the disease. They've done an amazing job on those two fronts.
Right, but let me say that if reality hits you, that is that you eventually become blind or visually impaired. There are organizations like PAVI to assist you with the rehabilitation or adjustment to blindness initiative. So all is not lost, because there is still life after blindness, irrespective of what age. Retina detachment is kind of common now. I know, before you go there though, I wanted to bring up one more thing about some of these countries, like in Africa, Asia again. I don't think we have too much of that in the Caribbean, which is malnutrition.
So, tell me again, what is it?
Malnutrition. Because of
malnutrition. Oh,
yeah.
Right. Yes, I think overall, I want to say I'm not too hot on the statistics for malnutrition, but in particular, vitamin A deficiencies and malabsorption were two problems that really sort of led to blindness, and very difficult to treat, once it's set in. So yes, you're right, malnutrition. But I have to say though, that again, through the efforts of charitable organizations and through the 80s and 90s, I think they did a lot of amazing work through Africa, and sub-Saharan Africa in particular, where there was a lot of malnutrition, marasmus, and kwashiorkor, where there's a protein deficiency. And if I'm not mistaken, they did a plumpy nut meal that they distributed through areas of malnutrition. And it's basically peanut butter enhanced with a lot of oils and vitamins. And it was just amazing. Peanut butter has got more protein per pound than steak. And it was able to treat those kids in particular who were malnutritious, and they did a great job. So I think since the 90s, I haven't heard too much of it, but I could be mistaken. It's kind of hard to stay on top of those issues worldwide. So,
not doing any advertising. Some people say, "I love peanut butter sandwiches."
Absolutely. Well, they won't have protein deficiency.
I don't know if Julian has any messages for us. I hear somebody's WhatsApp going to. Macular degeneration. Okay, we talk about that now. Doc?
Absolutely, macular degeneration. God, where do I begin?
Begin at the top.
Well, so I guess the most common form of macular degeneration is age-related macular degeneration. And they really come in two forms. Dry AMD, dry age-related macular degeneration. So my abbreviation for age-related macular degeneration would be AMD. So you have dry and wet forms of AMD. So dry forms are actually pretty common, but they're slowly progressive. Okay, so we can see somebody in 2021 and with early dry AMD and know that 8 years from now, they'll have reasonably good vision. Okay, so it's slowly progressive. And at the moment, there isn't an awful lot that is commercially available. What happens in dry AMD is basically we have a pigmentary layer in the eye called the RPE, the retinal pigment epithelium, okay? And the RPE, essentially speaking, does a lot of work for the retina. It manages a lot of the nutritions and hormonal requirements of the retina, and it kind of takes away all the waste products from the retina and gets rid of it. Now, the RPE, you lose about 5,000 cells every year. So if you're 10 or 12 years old, there's no noticeable difference. But as you get to like 70 and 80, the number of retinal pigment cells, epithelial cells, right, that we have lost becomes quite significant. So if you don't have an awful lot of retinal pigment epithelial cells, right, at about 70 on average, you'll start to notice window defects in the pigmentary layer. Okay, and that is really essentially dry AMD. Now, I'm going to say something. If you have very fair skin, you really don't have an awful lot of retinal pigment epithelial cells, okay? But if you have dark skin, you'll tend or whatever, you tend to have a lot of retinal pigment epithelial cells, okay? Because the more pigment cells you have in your body, the more they're going to manifest in your eyes, in your skin. And that's why in North America and Europe and China and Russia, they have a major problem with dry AMD because people are living longer. Medicine is getting better. The medications are becoming cheaper and readily more available. The research is telling us how to get people to live longer. And if I was to tell you the biggest change in the last 20 years is that every nationalized healthcare system has to actually change to treat diseases of the elderly a lot more because we're living longer. So geriatric disease is essentially something that is becoming a bigger and bigger issue. As you live longer, you're getting more of these issues: prostate problems, heart disease, dementia, AMD. So these are things that we are hearing a lot more of now because people are living longer. The average lifespan in Trinidad when I came back was 69. It's probably more like 75, so it's going up in Trinidad. If you look at the longest lifespan, Canada and Hong Kong they're well over 85 in their average lifespan. I think Okinawa in Japan is actually, that one area in Japan is over 1995. Like it's huge. So you're going to get more issues. And so in eyes, cataract, age-related macular degeneration are the two things that we're going to see more of because they're age-related problems. And so we have to find a way to get more pigment epithelial cells, retinal pigment epithelial cells. So there has been a couple surgeries looking at growing retinal pigment epithelial cells in a petri dish in a lab, right? Getting good quality growth of retinal pigment epithelial cells, and then taking them and transplanting them in the areas of the eye that your retinal pigment epithelial cells are lacking.
It's like a cell replacement.
Like a cell transplant, exactly. And so there's a lot of logistical problems with doing something like that. So again, it has been done. Patients have gotten an improvement in their vision, but we haven't taken people who are legally blind and made them 20/20 as yet. So there are issues. And we're a couple of years away from it. And then everybody talks about the microchip. The microchip is not something I'm overly familiar with, but I can tell you the technology is advancing. And so we can take people who are legally blind and give them the top letter on the Snellen chart, the visual acuity chart. And essentially speaking, that's a big difference for a lot of people who don't have vision. But we want to make it 20/20. So you have 15 more lines to go. So it's advancing. It's good. We're getting places, but it's not a perfect fix. And that's why you're not seeing it a lot more globally being used. Okay. So we talk about dry AMD, and there's something called wet AMD. So wet AMD is really different. It's actually on the opposite end of the spectrum. It's really fast, really aggressive. There's a growth of a vascular membrane. Okay, and we think some event happens where the blood supply to that area is interfered with. There's a change in the hormonal balance, and then there's this drive for blood vessel growth. Okay, and a lot of end-stage eye diseases end in angiogenesis or new blood vessel formation. We see it in diabetes, we see it in branch vein occlusions and central retinal vein occlusions, we see it in age-related macular degenerations. And in all of these diseases, there's a change in the natural hormonal balance, and it becomes a one-sided story, and it becomes pathological. So I started ophthalmology in 2002. And from 2002 to 2005, we had lasers. We had very fancy lasers. We had lasers with vertiporphyrin, something called photodynamic therapy, PDT, and all these fantastic therapies. They were very well performed, but it would only slow the progression of the blood vessel growth. So we tried to shut down the blood vessel growth, and we were successful until we tackled the drive for the changes. We really weren't getting very far, and we shut down the blood vessels, and the vision would not improve a lot of times. And really, over the years, we'd see a slow deterioration in their vision.
Okay, one of the things.
So fast forward to 2005, 2006, 2007, we actually started using injections in the eye, so what we call intravitreal injections. And intravitreal injections, a lot of people were skeptical. They were a little slow to take it up, but I remember the first time I did it, and I was like, wow, this is the future. This is amazing. For the first time, I was starting to see people's vision improve. It would improve overnight. Patients were doing amazingly well. We would shut down the vasculature, and it wouldn't come back. The disease wouldn't come back in a certain percentage. And for those that did come back, we would do another injection and would improve again. It was the first time we got visual impairment. And I was like, man, I think I could do this. I think this is something that we can do a lot more of. And came back to Trinidad, and people were still playing with it in 2007. And I do not blame them. I was very slow myself to do more of them. We didn't know what the long-term effects were. But, fast forward to 16 years down the line, and we have the evidence base. We know what the research is saying. We know that the risk of visual loss is minimal, and the number of lines or letters gained by a single injection or multiple injections is phenomenal. So the pros outweigh the cons by far. And you would have seen now in the last maybe 10 years in Trinidad where intravitreal injections have just exploded. I don't know anybody who's not been extremely unwell eye-wise, especially from diabetes and age-related macular degeneration, where they haven't been offered injections or multiple injections. It's just been amazing. Obviously, if we catch a disease a bit too late, injections may not help. Actually, sometimes injections, when you're on the severe end of the scale, can make it a little bit worse. So they're not all good stories, but
it's
the
all
vast
about,
majority.
It's all about timing.
Yeah, it's all about timing. It's exactly. It's all about getting it at the right time. Too early, it's probably not going to help. Too late, it's not going to help. There's a window of opportunity. That window is expanding. Some people need surgery. So it's hard to talk across the board for all the spectrum of diseases that intravitreal injections work for. And then I've also seen in that time intravitreal steroids coming in, and intravitreal steroids have also helped quite a bit, because we know that steroids are anti-inflammatory, and inflammation plays a role in some of these disorders as well. So, it's just been an exciting time. And as a teacher, it's been really exciting to teach this, to talk about my experiences pre-2005, and then to talk about it in 2021. It's just phenomenal. Patients are doing well. It's definitely a good news story. So I'm quite pleased by that. And looking to the future, it's only getting better. we know what molecules we want to shut down, and now we're starting to tackle the other isoforms as well. So there's something called VEGF-A, and the first treatment only treated 165 VEGF-A, and then we realized there's 4 other VEGF-As, and then Avastin actually, bevacizumab or Avastin tackled all those isoforms, and now with the next big jump for us was something called aflibercept or Ayala, and essentially Ayala didn't just tackle VEGF-A, it tackled it very strongly, and then tackled other molecules like placental growth factor. So that worked amazingly well. Its retention time in the eye stayed longer, and then now looking to the future, there's a drug that was approved about 18 months ago called brolucizumab, not available in Trinidad. There were some definite holdbacks, some definite concerns about the first couple of patients that got injected, but the FDA have been keeping an eye on that. But overall, it's been really a good news story with some concerns. So new drugs come out, we want to just sort of keep an eye on it and see.
I know you're all excited, but 2 things I need to clear up. I think we have one more commercial break, and to my producer director, we started at 6:15. Can we go the extra?
Are you asking me? Oh, right.
Okay, so let's go for that commercial break. When we come back, we talk about prevention.
Fantastic.
Courtesy is a presentation of persons associated with visual impairment. Previously on Courtesy.
Where the dead living around here? I come to go to the wake.
Well, you could have tell me that all the time. Come, let me show you. Watch where you're going, eh?
All right, thanks. I'll see you. And now, on episode 4.
Good evening. Good evening, Miss Mansing.
Who is that calling me this hour, boy? Do you realize Bold and Beautiful going and start?
Hello. Hello, Miss Mansing.
Hey, Tulum is you? What you want?
On my way home, but I'm feeling thirsty. I could get a glass of water to drink, please.
All right. But you have to get it yourself, eh? You ain't gonna make me miss the surprise on Brooke face when she hear about the telele with she sister and Regina. Hey, that is bacchanal! And besides, I sure you know inside my house better than me. What is that going on in there? Oh my, look how you bunks up yourself. I tell them children it's dangerous to leave the cupboard door open. I and all with my 2 big eyes just crash into it. Imagine for a blind person who can't see. Oh, gum. Look how you damage yourself. Let me call the ambulance. Hello? All you come quick. A blind man get damaged here, we.
Thank you very much. We just want to acknowledge that those scripts were written for us and produced by the late Ashford Joseph, who up until his death was indeed a very active member of PAVI, and we salute his family for allowing us to use these scripts as we continue our education of persons within the community. I don't know if you have any questions on your message board, Julia. Okay, well then I will ask the rest. Dr. Declan?
So I'm right here.
Right, so let's continue very quickly. I want to talk very basic, retinal detachment. I know you spoke a lot about the retina, and that is close to what we call the macular degeneration, right?
It's pretty different. It's pretty different actually, and it's a broad topic. All of these topics can essentially take an hour of their own time. So it's kind of hard, to
When
kind of
in any
brush
way-
across them. But retinal detachments are definitely, they've got their own spectrum and their own, diseases that they're related to. So which ones were we talking about? Just retinal detachments in general, or was there a specific one that you were thinking
No,
of?
in general, because I have heard that people in Trinidad do have, we have seen some clients who have had this problem and have come to us now.
Okay, so I'm going to rattle off a few conditions that are associated with retinal detachment. So, I mean, there is a physical retinal detachment called a rhigmatogenous retinal detachment that happens as a result of retinal tears, and it's more of a mechanical thing. The retina is like the wallpaper inside of a room, and if you tear that wallpaper, you could just, you could feel that it's not hard to picture the rest of the wallpaper just coming off over a period of time. And that's a mechanical problem and really requires a surgical correction. So we go in, we put the wallpaper back on the wall and we glue it all up. And that works amazingly well if we do it in time. Rhigmatogenous retinal detachments, ideally we would like to have operations within 3 to 7 days if we could. And there's almost no point really operating on a rhigmatogenous retinal detachment after 3 months. So there's a time scale. And obviously less than a week is going to do a lot better than anything else.
3 months, right.
That's not so common in the population. What's the biggest form of retinal detachments in the population is called attractional retinal detachments. And tractional retinal detachments are as a cause of, basically it comes out of that new blood vessel formation. We know that when you get new blood vessels, you get scarring, and that scarring causes the retina to be pulled up off its blood supply. And essentially speaking, the statistics for that are a little bit different. I would say it's probably worth operating on that up to 3 months, but probably not worth operating at all, or considering after 6 months or a year, there's probably no chance of visual recovery. And it is related to diabetes. It is related to things like retinal vein occlusions. It is also related to things like retinopathy or prematurity. And I think that's probably the next thing that I think the society wants to scale up the awareness of retinopathy or prematurity. We want to scale up the screening for that as well, which requires quite a bit of manpower. So I was saying earlier that people are living longer, but what is also happening in prematurity is we're getting babies who would have died from lack of care and lack of facilities actually living or surviving. So it was pretty abnormal for a child to do unwell over 32 weeks. And then there was this gray area between 28 weeks and 32 weeks. And then under 28 weeks was pretty difficult survival. But I think we're seeing more long-term survivals out of those premature babies. If I'm not mistaken, with the best care, it's about 50-50 if you're 26 weeks birth. So they tend to have a lot of issues. But I can also tell you the younger they are, the more likely they are to develop something called retinopathy of prematurity. And that can be a very aggressive disease in babies. So what we're finding is that babies are surviving now, but they're blind.
Okay.
And that's a problem.
Right. I want to go on to one more in the area of blindness before we talk about things that you don't do or you shouldn't do. And that is tunnel vision, because a lot of people have tunnel vision.
Sure. Well, tunnel vision is pretty worrying. If somebody's got tunnel vision, well, first of all, let me explain what tunnel vision is. So tunnel vision is essentially where you're not able to see, you can see things in front of you, but everything on the outside is absent, black or blurred. And there's lots of reasons. Well, there are a couple of reasons why that might happen. There's a particular area in our visual pathway where those nerve fibers cross. And if they get compressed, usually from a tumor, but it can also happen from aneurysms and other vascular problems like pituitary apoplexy, which is an acute hemorrhage in the pituitary gland, then you can get this acute compression, and it affects all your nerve fibers on the outside of your vision, and you're only left with this central column of vision in front of you. And so it can be slow, which is harder to pick up on, or it can be very acute. Either or, they're pretty dangerous. And a lot of times those patients need scanning, MRI scans, CT scans, blood tests, and essentially speaking, we need to treat the problem compressing the optic chiasm. So those nerve fibers don't like to be compressed. And sometimes when you press them really hard and you let go, they don't actually recover. So the idea is we save vision, but also we want to make sure that whatever is causing it doesn't also cause problems for the patients. So like tumors, obviously they're life-threatening. Aneurysms are life-threatening. Pituitary apoplexy is life-threatening. That's actually a neurosurgical emergency. So the causes are really quite severe. So tunnel vision is definitely something that comes up from time to time. And yes, they are quite worrying. So the ophthalmologists tend to find it, and then the neurologists and the neurosurgeons tend to treat it. So you're seeing again in medicine multidisciplinary approaches where you actually have teams of doctors looking after one patient with particular conditions because it crosses all the different specialties. So we look after the eyes, they look after the pituitary glands, and patients usually have the best outcome in those scenarios. So.
And let's make the point that a person who has one problem, like for example, somebody with glaucoma could also get other eye diseases. It's very likely, depending on your own state of health.
So that's why we regularly screen people with glaucoma, because there are not too uncommon now. There's dual pathology, and about once a year, I'll have patients that I look at and I'm like, this is not behaving like glaucoma. And scans really help us with that. Visual fields tests, OCT scans, which I had mentioned before, are essentially MRI scans of the eye, but give you 100 times more information than an MRI scan could ever give you. These things help us to delineate glaucoma from other diseases as well. So getting it right on day one means you're not delayed in terms of getting the correct diagnosis. And then we know we've established the correct diagnosis. And then also we find that they develop some other dual pathology somewhere along the visual pathway, like the tunnel vision. So there's certain neurological visual fields we see. And essentially, once we think it's going down that road, we tend to go to brain scanning. And again, in Trinidad in 2021, there's no shortage of availabilities of brain scans in the public or private sector. So it is something that we have a low threshold for. And I have to say, most times we figure it out. I had a guy maybe about 2 years ago, lovely fella, came in. We were querying glaucoma, and just had a mild outline, very early outline of tunnel vision. I had a look at it and I said, you've got some shadows there, and I don't think it's from glaucoma. So that's your brain scan. He was 50-50 walking out the door. Thankfully, he came back, said, doc, I just want the scan. Did the scan, and he had a massive pituitary tumor there. I think it was 4 centimeters, almost 2 inches. So it was huge. So, he went in, got the treatments, and has done amazingly well, actually. So really, really happy about those sort of results. But yeah, that is something that your ophthalmologist and your doctor should be doing. It's why we usually ask that eye doctors be the ones that screen, have a look, and make the decisions as well. Because if we make a mistake here, there's a high price to be paid, in terms of vision, it's important. We usually only have 1 or 2 shots at certain things, at finding them, and if we're delayed, it's a real problem to fix them later on. So we feel strongly as a society that the ophthalmologists always play an integral role into these scenarios. And a lot of times you can be fooled into believing it's a simple issue of just doing field tests and OCTs. You got to be pretty discerning. And, we say doctors, but, really you're like a detective. You're there snooping around, trying to find clues to see if there's other problems. I think doctors are the best doctors are the biggest skeptics. They don't just accept what they're being handed. They always challenge everything. And I think that's a secret to really finding these diagnoses and getting patients to do well, just by challenging everything that you see and knowing what to do when you're caught in those situations.
All right, in the few minutes that we have, and let me apologize for that background noise, it's something that I have no control over. We see that there is a lot of dust around, Sahara dust. I know in some countries like St. Vincent, like Barbados, they have not just Sahara, but they also have the volcanic ash. But what some of the things that we can do to prevent eye damage, so to speak, in terms of how we treat, how we wipe our eyes? Because a lot of people take a lot of things for granted.
Well, it's not an easy topic to tackle. I just think there's a lot of minor eye diseases out there, like there's a lot of meibomian gland dysfunction, blepharitis, allergic eye disease, dry eyes. And what happens is that you get this diagnosis from, optometrist, ophthalmologist, whatever, and then the Sahara dust comes in, and it just, whatever your symptoms are, it makes it worse. It just makes it more severe. It makes it more difficult to work with. I have about 5 or 7 patients now that I'm getting used to that, they'll just say, oh my God, this week it's just been worse. And I don't know what's going on. And I'll be like, I'll go home and Sigourney will be like, oh, Sahara dust explosion today or this week. It's the Sahara dust just sort of making it worse. I think there's always eye drops that you can take to soothe the discomfort. I mean, there's lubricants, there are
eye washes.
Steroids, yeah, there's steroids, and there's things like antihistamine eye drop, like Lasticaf and Pataday. They're 2 excellent eye drops. Pataday has been around for a long time, but Lasticaf as well is relatively new in the market. It's doing a great job as well. So
all in all, what you're saying is that there are things that you can do, that you can use to treat the eyes under these circumstances.
Yeah, well, what I'm saying is whatever condition you have, irritating eye condition you have, Sahara dust makes it worse. And then I think treating the underlying eye condition, when you know there's about to be a Sahara dust explosion or upsurge, I think is important. Some people let their eye drops go, their medications go. We give people exercises like lid hygiene to do to clear out the bacteria and toxins from glands and meibomian gland dysfunction. And sometimes they lapse after a little while, and then the Sahara dust comes along and reminds them that this is something that they need to do. The research has kind of helped us a lot to make things like lid hygiene and eye drops and everything more effective. We have better solutions. We have more things that we're adding. I know for some of my patients, I'm adding just a drop or 2 of tea tree oil, and it's been working amazingly well for them. Now, that should never go directly into your eyes, but there is a solution that we give people to use, essentially a homemade solution that sort of clears the toxins and bacteria from the glands in and around the eyes, and that is remarkable. It helps a lot of people amazingly well, and it's definitely something that I have to recite anywhere between 5 and 7 times a week to get them feeling better. So I think the most important thing is to identify whether Sahara dust is something that affects you, and if it is, you got to keep an eye on it. and just brace, batten down the hatches and brace just for that those couple of days. But the lubricants, you can use lubricants every hour in really irritating eye disease, and it works amazingly well. It's like an eye wash.
Well, Doc, I think that's where we're gonna leave it. Yeah, I didn't know that. Well, you substituted for your father, but you did yeoman service for the last hour or so. And if we had more time, we'd have had more conversation. But let me thank you very much for making the effort to be here this evening, representing your dad. And let me thank our colleague out there at Mended Studios, Julian. Let me thank you, our viewers and listeners. And of course, next month, with the good Lord willing, and the creeps don't rise, we have another special session for you on the PAVI segment. And in the meantime, and in between time, just want to remind you that you can make a contribution towards this initiative and the work of PAVI in general. The telephone number to call is 220-1073. And of course, as I always say, an ounce of prevention is better than a pound of cure. Thank you, Doc. Thank you, Julian. Thank you, viewers, listeners. Adios. And remember, continue to observe the COVID protocols.
Never leave me. Jaja, protect me. Jaja, protect me. Never leave me. Father God, in your arms, I want you keep me. Never leave me. Jaja, protect me. Jaja, protect me. Jah be my shield. Jah be my shield. Even in the midst of my enemies, Jaja want to cover me. Jah be my shield. Jah be my shield. Father God, protect me. Jesus Christ, defend me. Jah be my shield. Jah be my shield. Even in the midst of my enemies, Jaja want to cover me. Jah be my shield. Jah be my shield. Father God, protect me. Jesus Christ, defend me. Father, I see you standing by the corner, you I see them. But gun in the hand, you I see them. My life, the one that teach I Lord, I hope you see them. Father, I see them. Smiling like but in the heart they really hating. My life don't wanna see come to end, but me beg you Jesus, please protect me from them, so me sing again. Jah be my shield, Jah be my shield. Even in the midst of my enemies, Jaja want to cover me. Jah be my shield, Jah be my shield. Father God, protect me. Jesus Christ, defend me. Jah be my shield, Jah be my shield. Even in the midst of my enemies, Jaja want to cover me. Jah be my shield, Jah be my shield. Father God, protect me. Jesus Christ, defend me. 1,000 on me left, 10,000 on me right. Father God, me beg you please put them demons to fight. Cause everything you give I don't wanna steal. Me house, me car, me land, Father, they wanna steal. The money in the bank, they wanna steal. The woman in me life, they wanna steal. The peace and the health you a give I. Me family, they wanna destroy. That's why they say, Jah be my shield, Jah be my shield. Even in the midst of my enemies, Jaja want to cover me. Jah be my shield, Jah be my shield. Father God, protect me. Jesus Christ, defend me. Jah be my shield, Jah be my shield. Even in the midst of my enemies, Jaja want to cover me. Jah be my shield, Jah be my shield. Father God, protect me. Jesus Christ, defend me. Never leave me. Father God, in your arms, I want you keep me. Never leave me. Jaja, protect me. Jaja, protect me. Never leave me. Father God, in your arms, I want you keep me. Never leave me. Jaja, protect me. Jaja, protect me.
Jah be my shield. In the midst of my enemies, Jaja wants to cover me. Jah be my shield. Jah be my shield. Father God, protect me. Jesus Christ, defend me. Jah be my shield. Jah be my shield. In the midst of my enemies, Jaja wants to cover me. Jah be my shield. Jah be my shield. Father God, protect me. Jesus Christ, defend me.
Jah be my shield, Jah be my shield. Even in the midst of my enemies, Jaja want to cover me. Jah be my shield, Jah be my shield. Father God, protect me. Jesus Christ, defend me. Jah be my shield, Jah be my shield. Even in the midst of my enemies, Jaja want to cover me. Jah be my shield, Jah be my shield. Father God, protect me. Jesus Christ, defend me.